First of all, I would like to thank the organizers for inviting me to speak on modified Atkins diet for the treatment of persons with drug-resistant epilepsy, a randomized controlled trial. So as we all know that 1/3 of the patients with epilepsy, they continue to have seizures despite the treatment with anti-seizure drugs. And the diet therapies have been reported to be effective, safe, and can be administered synergistically with other treatment options. Modified Atkins diet is as effective as classical KD for the management of drug-resistant epilepsy. In the systematic review by Martin McGrill in 2018, that included around 11 randomized controlled trials, including 712 children and around 66 adults. And it was noted that with classical KD, the seizure freedom was as high as 55%, and the seizure reduction was 85%. And with modified Atkins diet, the seizure freedom was up to 25%, and the seizure reduction was 60% in children. So let's begin with what is ketogenic diet first. It is defined as high fat and low carbohydrate, moderate protein diet that aim to force the body to break down the fat instead of glucose. So we have this diet which consists of 1:1 to 4:1 ratio of high fat and low carbohydrate and adequate protein. So with mean ratio, what I mean is this is the relationship between the grams of fat and the combined gram of protein and the carbohydrate. For example, the meal ratio of 4:1 means that it has 4 grams of fat and 1 gram of carbohydrate and protein combined. So the types of ketogenic diet vary in the nutritional compositions. So basically, we are using 4 types of therapy, ketogenic diet, which is classical ketogenic diet. With this classical ketogenic diet, the KD ratio is 4:1, which is very high in fat. That means that 90% of the fat comes from the total calories, wherein in modified Atkins diet, we fix the carbs to 10 to 20 grams for the whole day, and the total fat percentage is around 60 to 65%. In medium chain triglycerides, we give around 60 to 75% of the fat from total calories, whereas in low glycemic index diet, which has glycemic index less than 50, we give around 60 to 70% of the fat from the total calories. Now, coming to the mechanism, how does it affect? How does the ketogenic diet affect the seizure reduction? There is a decrease in glutamate and increase in GABA. And there are a lot of mechanism which has been, given by the researcher. There is an increase in voltage-gated calcium channel inhibition. It activates, ketogenic diet activates the potassium channel, which thereby it hyperpolarizes the neuron, and thus it limits the excitability. There is also an increase in mitochondrial biogenesis, which increases the mitochondrial function. Another theory says that this decreases the glycolysis, thereby it decreases the cellular excitability. Another study done in Cell, and it says that the KD ketogenic diet modifies the gut microbiota with a decrease in alpha diversity and increase in the putative beneficial bacteria. The beneficial effect of ketogenic diet on epileptic seizures are mediated by the gut microbiome through their modulation of hippocampus gamma versus glutamate ratios. Now, this is very important. Before we start the diet, a multidisciplinary diet therapy team is important, which consists of a neurologist who is familiar with the ketogenic diet. A dietitian is mandatory for the classical ketogenic diet, but optional for the alternative diets like modified Atkins or low glycemic index diet. The ketogenic diet counseling, evaluation, and the follow-up should be done by a multidisciplinary team. Neurologist is responsible for the overall epilepsy management, whereas a dietitian is required to do the nutritional prescription, nutrition education on implementation and maintaining the diet therapy. A very close monitoring of the patient regarding the nutritional status, adjustment of the diet plan, and the fine-tuning of the diet is done by the dietitian. So here the dietitian plays a very important role in initiating and fine-tuning the diet. A psychologist again helps the transition of diet and maintain the adherence of the diet. So it is important for this diet to be started that we should have a multidisciplinary diet therapy team. There are some prerequisites before we start the ketogenic diet. According to the International Ketogenic Diet Study Group, they recommend there should be a structured parental counseling and informed consent should be taken by the parent. Nutritional assessment has to be done, and certain laboratory investigations pre-ketogenic diet therapy is must. As regards to the screening, it is important that before we start a ketogenic diet therapy, a patient needs screening for the biochemical testing of blood and urine, for the disorders of fatty acid metabolism, and the organic acidureas that may lead to the deterioration. So certain prerequisites for the diet is to maintain the Caesar diary, baseline height, weight, ideal body weight, and which is required to calculate the ketogenic diet ratio, calories, and fluid intake. 3 days food recall is must to be taken. So, certain informations like food preferences by the patient, certain allergies, if the patient has some aversion or intolerance towards the food is also noted at the time of the diet recall. Certain medications which has sugar like in that needs to be taken into consideration. Mandatory biochemical analysis for lipid LFT, KFT, lipid profile, certain urine routine or calcium creatinine ratio is important to rule out any stone in the patient. Some of the investigations like EEG, MRI are also important before we take the patient for the counseling. So nutrition evaluation is important to establish the diet formulation, whether we need to give oral or enteral or the combination of these two. Decision on what type of diet is to be started, like classical KD or medium chain triglyceride diet, modified Atkins diet, is decided based on the information which we gather at the time of enrolling the patient. All that is important that we need to calculate the calorie, protein, and ketogenic diet ratio of the patient. Establishing the vitamin and mineral supplementation based on the dietary reference intake is again important. And to minimize the carbohydrate content, syrup to tablet or sugar solution wherever feasible is again taken into the consideration. This was a study which was published in JAMA in 2020. This was done by Sondi et al. Regarding the efficacy of ketogenic diet, modified Atkins diet, and low glycemic index diet therapy amongst the children with drug-resistant epilepsy. And they reported that all the three variants of the diets are equally efficacious, but they also reported that the compliance and adherence of the diet was more in modified Atkins diet and low glycemic index diet as compared to the classical ketogenic diet. It is also very important to know the indications and contraindications before we start the diet therapy. And it has been reported that the ketogenic diet is used as a first line of therapy in certain disorders like glucose transport protein 1 deficiency, pyruvate dehydrogenase deficiency, myoclonic astatic epilepsy, tuberous sclerosis complex, Rett syndrome, and certain selected mitochondrial disorders, where it should not be used in the patients who have the beta oxidation defect, primary carnitine deficiency, inadequate ability to comply with diet, or who have the severe GI gastro reflux problem. This is a schematic flow chart, what we do in our center for the counseling. Once the patient referred to us, we take the baseline investigations, then followed by educating the parents regarding the modified Atkins diet. We provide the recipe book and we teach them how to check the ketones in the urine. The ketone diary and the Caesar diary is also provided at this time. We start with a washout diet, wherein we give minimal carbohydrate in order to get the ketones faster in the urine, followed by diet prescription, which is 20 grams. In our center, we restrict carbohydrate to 20 grams for adult patients, and the children below 10 years, we give 10 grams of carbs for the whole day. Then followed by monitoring and follow-up for at every 6 months, 3 months to 6 months. So this modified Atkins diet was introduced in 2003. This is a less restricted form of ketogenic diet, and it provides around 60 to 65% of the calories from fat. And we give the ratio from 1:1 to 1.5:1. This is the most liberal nature of diet, and there is ease of administration. That is why it makes it a promising choice, especially for resource limiting settings. This is the protocol, what we follow in our center. It is also very important to give the dietary supplementation, multivitamin supplementation, mineral and calcium when we take the patient for the ketogenic diet. These are the phases of the diet, starting from pre-diet counseling, followed by carbohydrate washout. Then we plan the diet and the prescription is given to the patient, followed by the post-follow-up phase. So in pre-diet counseling phase, initial dialogue with the parent regarding the feasibility, availability and affordability, and also the social issues are discussed. We need to identify the presence of swallowing difficulty like poor weight gain, GERD, constipation, if any cardiomyopathy or chronic metabolic acidosis. Administration plan of diet therapy needs to be discussed with the family and the neurologist. We also need to know the parents' expectations from us and the realistic treatment goals. This is very important before we initiate the diet. That is pre-diet counseling phase. Followed by the carbohydrate washout. As I said, that this is restricted in carbs, so we don't allow initially for 2 or 3 days minimal carb vegetables and fruits. We allow them to have carbs-free foods here, like from non-vegetarian foods like fish, chicken, egg, or soya products, and also certain free foods which are sugar-free jellies and carbs-free foods are allowed at this moment of time. And we have seen in our patients that within 2 or 3 days of the carbohydrate washout diet, they get this moderate ketones. After this, the diet is prescribed, that is modified Atkins diet. We plan ketogenic diet once the ketones are reached to 4 plus. The keto ratios are then decided to 2:1 to 4:1, depending on the seizures of the patient. The calorie level is determined by the dietitian based on their age and activity level and estimated RDAs for ideal body weight. The dietitian devises the meal plan that complete the required fat, protein, and the carbohydrate for each meal. So the ratios are determined and the ketogenic diet is started. This is the modified exchange list, which we have devised in our center for the ease of applicability and to give the variety to the patients. So this chart shows that all the items which are listed here in this exchange list has around 2.5 grams of carbohydrates. So the patient is allowed to have around 8 items out of this list, so that they can just make the changes in the meal and have a lot of variety. Apart from this carbohydrate list, we give them 0 carbohydrate foods, which are from chicken, fish, non-vegetarian food, and soya products like soya granules, soya rava, soya dal, and fats and ghee and butter, mayonnaise are encouraged. Fourth phase consists of fine-tuning of the diet and followed by the follow-up plans. And the main objective of this diet is to achieve and maintain the ketone levels to achieve the optimal seizure reduction. Calorie and ratio are adjusted to maintain the ketones, that is moderate ketones. Regular follow-up with the physician and the dietitian is required at this time. And we also ensure that all the supplements keto diary records are maintained in the standard format. We also check for the hidden carbs in the diet, like medicines. We check for the mannitol. Certain sugars are there in certain foods like mannitol, maltose, lactose, and all that is checked by the dietitian while taking the diet record. The fine tuning of the diet is done by the dietitian. For example, if the weight is normal and the ketones are between 2 to 3, that is moderate, and there is an increase in seizure from the baseline. So what we do, basically, we don't change the calories here, and we just increase the ratio from 2 to 2.5:1. So that is how the fine tuning is important to get the desired result. Monitoring again is very important. We check every 3 months, we check the weight and height. The ketone levels are checked. We verify the accuracy of keto sticks. checking the urine report, like to check the urine for stones. Any problem related to digestion, appetite, and the recipe feedback is taken at the time of monitoring, and that has been noted out. This is a ketone monitoring strip, which is explained to the patient how they have to document it, and that is the actual demonstration of this is given at the time of the clinic visit when we start the diet. Certain short-term side effects are seen in some of the patients, which can be managed by slight modifications in the diet. Like in case of dehydration, we give plain water, soda with sugar-free tablets. We can also give lemon juice if the dehydration is there. And certain patients, we don't come across any patient with hypoglycemia in modified Atkins diet. This is more seen in the patients who have who are given classical KD, which we don't practice in our center. If the patient has nausea or vomiting, then we just give them plain soda with flavors, that is sugar-free. And constipation can be resolved by advising the patient to give adequate fluid and include the vegetables which are high in fiber. In certain illnesses like fever, cough, and cold, we tell them to continue the diet, and we ensure that adequate fluid intake is offered, which is sugar-free, and semi-solid foods are offered. It is also very important not to discontinue the diet. It should be done under the guidance of a dietitian who is trained in keto diet. So it is usually implemented for 3 to 6 months, the diet. And if we get the poor response from the patient, so the consensus group agreed that ketogenic diet should be used at least for 3.2 months in order to make a fair assessment of efficacy. In those patients, if there is more than 50% seizure reduction, we can give the diet, and we can KD are often discontinued after 2 years. And in patients where we see more than 90% seizure reduction, it can be continued for several years. Regarding supplementation, all those children should receive a daily multivitamin L-calcium with adequate vitamin D. The oral citrates appear to be to prevent the kidney stones, but there is a class 3 evidence for this. So there was a mixed opinion on empiric use. Vitamin D level decreases on KD, but there's a mixed opinion. So there's no recommendations for the empiric use of antacids, laxative, probiotics, additional selenium, or carnitine with KD. Again, it is important to give the education and motivate the patient by support group, education material or publications, which is very useful and should be encouraged. Pre-ketogenic diet counseling provides an opportunity to involve family members and their close relatives in diet planning. So it has seen that these strategies, we should aim to motivate the individual to change their diet. And also we allow them to use locally available food, which should be included in the recipe, and time-saving techniques are also advised by the dietitian. We have also started using telemedicine approach for the patients who stay in distance, so that if they can also utilize this, diet therapy, who are not getting relief out of the medicines. This was a study which was done in our center. This was safety, efficacy, and tolerability of modified Atkins diet in persons with drug-resistant epilepsy. And this was published in Neurology in 2023. And it was found that at 6 months after taking modified Atkins diet, the patients, more than 50% patients, there was a reduction in seizure from baseline as compared to 26.2% of the patient had more than 50% reduction as compared to 2.5 in control group. The median percentage reduction in seizure from baseline was higher in diet plus medication group. And also we have seen there was a significant improvement in the quality of life and the behavioral scores in the diet plus medication group. This was the study protocol. So I have already discussed what protocol we follow in our center. And the compliance of the diet is also checked to evaluate this adherence. The ketosis is assessed daily with ketone and using keto diastics. And also the compliance is checked by the food diary, which the patients maintain every day. They are required to, write down the carbs, daily carbs. They are, they have to maintain this food log daily, so that the dietitian can calculate the ratios, the food ratio, and the amount of carbohydrate the patient is eating. Caregivers were asked regarding any difficulties they faced with understanding instructions and preparation of the diet. So we checked the compliance of the diet using the keto diastics and the food log. This I've already discussed. The compliance was very good in our study, as high as 80%. We also have seen that there was improvement in quality of life. So it was very significant in both the groups, like adult and adolescent. We did the subgroup analysis also, because we had patients between 10 to 55 years. So in both the groups, the quality of life score was significantly high in diet versus control group. We also have seen that there was a good there was a improvement in behavior in the group which were offered modified Atkins diet versus the control which was not given that diet. The side effects were very minimal in our study, and we found that in 6 months, only 2 patients, like 4.3% of the patient had constipation, and around 2.1% had weight loss. So one can, like, as regards to the primary outcome, in our RCT, we investigated the effect of add-on modified Atkins diet therapy on seizure reduction in adolescent and adult with DRE, and it was found that MAD was more efficacious in reducing the seizures than the standard diet drugs alone. This study was conducted in a large cohort, including adolescent and adults, with 6 months follow-up. So the strength of our study was, this was the first study to analyze the efficacy of modified Atkins diet in drug-resistant epilepsy with a large sample size, covering the wide aspect of seizure reduction, adverse events, quality of life, and behavior using the objective scales. A simplified version of food exchange system was also developed for the ease of applicability in modified Atkins diet. We offered the wide choices and food substitution that helped to create their meals. Significantly better results for adults as compared to the adolescent were found. The limitations of our study was that this was an open label design. Blinding was not possible in our study, as the diet prescription required very close parental interaction. The use of parental seizure recording runs the risk of subjective error. It was difficult for the parent to count all the seizures in adolescent with numerous daily seizures of multiple types. So it is important that a pre and post objective long-term video recording would have been the better idea to assess the outcome. But in our clinical setting, it was not feasible and beyond the scope of the present study. So I can conclude by saying that in adult and adolescent with DRE, the administration of modified Atkins diet as an add-on therapy, ongoing anti-epileptic drug therapy, is more efficacious after 6 months of intervention as compared to the control. The reduction of seizure frequency was reflected in the improvement in quality of life and behavior as compared to the control group and diet group. So the further research is needed to study the long-term outcome of the diet on the seizure control and the biochemical parameters in adult, its effect of bone health and cardiovascular health, insulin resistant and metabolic syndrome, and also in cognition. It is also important to identify the neuropsychological and genetic biomarkers as associated with modified Atkins diet. Thank you so much.
Hello, my name is Dr. Stephen Brown. I am a doctor of chiropractic and a chiropractic expert witness, here to present my 2024 paper, Plausible Mechanisms by which Cervical Spine Manipulation can cause immediate stroke. This study was published in the journal Curious, C-U-R-E-U-S. If you want to look it up and follow along as I go along, it is online. This is the usual lecture I do on this topic. It's about 8 hours long. We only have time for hour 3, and we only have 20 minutes, so it's going to be a little fast. So if you want to follow along in the study, you're welcome to. We won't be able to cover everything in the study because we only have 20 minutes, but I'll get the highlights for you, especially the first study. The abstract of the study, it has been proposed that manipulation, cervical spine manipulation, can cause cervical artery dissection in healthy cervical arteries. By cervical arteries, we mean the vertebral artery and the internal carotid artery. This has been proposed to cause resultant immediate stroke. However, the research does not support this. The research does not support a causal association between manipulation and dissection in healthy cervical arteries. But this does happen. People do have manipulation and they do have immediate strokes. This is a phenomenon that happens. How do we explain this if the manipulation is not tearing the artery? The objective of this study was to review the literature to identify plausible mechanisms of causation of immediate stroke by manipulation. Immediate stroke defined as stroke occurring within seconds or minutes of manipulation, not hours, days, or months. Plausible thromboembolic and thrombotic mechanisms of causation of immediate stroke by manipulation were found in the literature. The common premise of these mechanisms is that the dissection was present before the manipulation. It did not occur as a result of the manipulation. These mechanisms of causation have clinical and medical legal implications for physicians performing cervical spine manipulation. Our literature search, we searched PubMed and the index to chiropractic literature with the terms chiropractic, stroke, dissection, cervical spine manipulation, vertebral artery, and internal carotid artery. We included studies, peer-reviewed and academic studies that proposed a plausible mechanism of causation and excluded the ones that did not. These are our 12 results of our literature search, 12 studies from 1989 to 2016 from neurologists, chiropractors, and physical therapists, so a wide variety of professions weighing in on this topic. 1989 Moss case report from Jean-Louis Moss, a neurologist out of France. Dr. Moss writes, a previously healthy 35-year-old woman consulted with a doctor of chiropractic following 3 weeks of cervical and occipital pain. She had 2 cervical manipulations on successive days. About 1/2 hour after the second manipulation, she complained of a paresthesia over the right side of her body and then over the left, in both instances sparing the face. There was no dysphagia. She then became comatose over the course of 15 minutes. She died 10 hours after admission, 16 hours after the onset of symptoms, or 16 hours after the manipulation. Dr. Moss writes, the most likely mechanism of brain ischemia in the present case was artery-to-artery embolism from the right vertebral artery to the basilar artery with subsequent fragmentation and disappearance of the clot. Moss goes on to give us some details. In this case, the lesions of different age within the dissecting aneurysm were a striking finding not previously described. This is 1989. The lower part of the dissection contained an organized thrombus a few weeks old, composed of fibrocytes and neovessels, while the upper part contained a recent thrombus formed of fibrin and blood cells. Chiropractic manipulations less than 3 days before death could have accounted for the recent dissecting aneurysm, but not for the other. This latter aneurysm, which was a few weeks old, dated from approximately the same time as the onset of the cervical and occipital pain. And Dr. Moss includes slides from the autopsy here showing the difference in the thrombi, the older and newer. This is worth looking at. Moss concludes, thus, cervical pain that precedes and motivates chiropractic cervical manipulation may be the first symptom of a hitherto unrecognized, spontaneous, or traumatic dissection. In such a case, cervical manipulation would precipitate stroke by either worsening arterial damage, leading to positional occlusion of an already narrowed artery, or dislodging an intraluminal thrombus. Thus, the 2 mechanisms. 1, the thromboembolic mechanism. Manipulation could dislodge a pre-existing intraluminal thrombus, causing it to embolize to the brain, blocking a smaller artery, causing ischemic stroke. Mechanism number 2, a thrombotic mechanism. Manipulation could worsen pre-existing arterial damage or dissection, leading to positional occlusion of an already narrowed cervical artery, causing ischemic stroke. These 2 mechanisms were proposed by Moss in 1989. The other 11 studies we found basically repeat these mechanisms. There is support for this. This was 34 years ago in France. This study's been out there a long time and no one has paid much attention to it in the popular chiropractic media, but 11 other people have. We're going to go over those briefly so you can see that Dr. Moss was not alone in this. And these two mechanisms do explain Every case of immediate stroke after manipulation I have reviewed as an expert witness. This explains the phenomena. And that's what a good scientific theory does, explains observed phenomena in nature. This explains the phenomena. In 1999, Dr. Haldeman, a chiropractor and a neurologist, he came to the same conclusion that this could be caused by a thrombotic mechanism, an embolus being dislodged, or a thrombotic mechanism, a vascular occlusion blocking the artery after manipulation. In 2000, Dr. Norris, a neurologist out of Canada, came to the same conclusions. These mechanisms were either going to be thrombotic or thromboembolic. In 2002, Haldeman came back with another review of malpractice cases and came to the same conclusions. These strokes are either thrombotic or thromboembolic, and the dissection walked into the office. It was not created by the dissection. Dr. Smith, a neurologist out of California, came to the same conclusions in 2003. The dissection walks into the office, and the manipulation is either extends the dissection or dislodges it, causing thrombotic or thromboembolic stroke. In 2008, Cassidy, a doctor of chiropractic, performed an epidemiological study, and he took into account that this could happen when he designed his study. The actual mechanism of thromboembolism was designed into his study. Here on the third line, for the chiropractic analysis in our study, the index date was included in the hazard period. Since chiropractic treatment might cause immediate stroke, and patients would not normally consult a chiropractor after having a stroke. This is a direct quote from the study. He specifically says, we have not ruled out neck manipulation as a potential cause of some vertebral basilar artery strokes. He specifically says it might also be possible that chiropractic manipulation or even a simple range of motion examination by any practitioner could result in a thromboembolic event in a patient with a pre-existing vertebral artery dissection. So this study does not rule out that manipulation can cause stroke, like many people think it does. What they found was the increased risk of stroke associated with chiropractic and primary care visits, they found both, was likely due to patients with headache and neck pain from an existing dissection seeking care for their stroke. This is consistent with the thromboembolic and thrombotic mechanisms, which require that the dissection be there before the manipulation. They found no excess risk of stroke compared with chiropractic care compared to primary care. They didn't say they found no risk. They said they found no excess risk. The risk was the same. So the risk of walking into a chiropractic office or a medical office with a dissection and the practitioner failing to diagnose and refer it are the same. Apparently, chiropractors and medical doctors are just as bad at diagnosing and referring dissections according to this study. So the conclusion could be we found that chiropractors and PCPs fail to diagnose and refer VBA dissection at the same rate. So this study does not conclude, but a lot of people think it concludes. 2009, Dr. Schwartz, a neurologist out of California, came to the same conclusions. They could be a thrombotic or a thromboembolic stroke. Dr. Albuquerque, a neurologist out of Phoenix, Arizona, Barrow Neurological Institute, came to the same conclusions again. These strokes could be caused by thromboembolic or thrombotic mechanisms. I know we're going fast here. Dr. Tushin, a chiropractic researcher out of Australia in 2013, was one of the first chiropractors to really come out and state this plainly and clearly for the chiropractic profession to soak in. Apparently, not many people have actually read this study in the chiropractic profession, or they don't understand it. Tushin says physical triggers, including manipulation, can serve as a plausible final link between the underlying disease and the stroke. For instance, in the case of an arterial dissection with existing connective tissue weakness. If someone has a dissection because their artery is already unhealthy and they walk into a chiropractic office with that dissection, those two mechanisms could be engaged. If the healthcare practitioner did not take a thorough clinical history, they may overlook these above factors, the dissection. They may fail to diagnose the dissection, and they may perform a manipulation when it may have been contraindicated. Therefore, an existing dissection is exacerbated, the thrombus is dislodged, and creates the stroke. So this is in the chiropractic literature. 2015, Whedon, another chiropractor, concluded that because dissection and associated thromboembolism are the most plausible mechanism by which manipulation could cause a stroke, our findings support the current best evidence suggesting that manipulation is unlikely to be a significant cause of stroke in older adults. And this makes sense. Wheaton was studying Medicare B beneficiaries aged 66 to 99. This age group is not likely to have a dissection. So if they're not likely to have a dissection, they're not likely to have that dissection aggravated into a stroke by manipulation. And Wheaton states very clearly right here that the thromboembolic mechanism is plausible. Some of this research has been either not seen or ignored by the chiropractic profession, as they are still in some denial about this. The physical therapy profession is a little better at that. They recognize this can happen. Dr. Thomas, a physical therapy researcher out of Australia, states that manipulation performed when a dissection is present could further damage the artery or propagate an embolus. What cannot be ruled out is the possibility that manipulation or trivial neck strain may cause dissection in a susceptible artery, extend the dissection, or propagate an embolus. Dr. Thomas notes that there must be a close temporal relationship for this to actually happen. There must be a period of seconds or minutes between the manipulation and the stroke for this mechanism to be actual. And there's even more. In 2016, German neurologists Nieb and Reuter, in a chapter out of a textbook which they wrote, they observed that dissection that leads to stroke in a temporal relationship to manipulation is not necessarily caused by the manipulation. People with dissection commonly experience neck pain, which is often misdiagnosed as pain of musculoskeletal origin. For the treatment of neck pain, these patients may seek manipulation, which could contribute to the risk of stroke by exacerbating the pre-existing dissection or dislodging an embolus, the same two mechanisms that Moss studied in 1989. Here's a summary of our 12 studies, 1989 to 2016, a collection of neurologists, chiropractors, and a physical therapist. These mechanisms are in the literature. They're not hidden. This should not be a controversial topic, but it is. So I'm trying to get the word out that this should not be controversial. There was one contrary study we found, 2008 Wynn study. She tried to recreate dissections in the cervical arteries of dogs and then manipulate them to see if the dissection would be altered or dislodged, and it was not. However, this study was not convincing because they did not perform the dissection at the same level it normally happens in humans. They did not wait very long from the creation of the dissection to the manipulation, so the dissection never had time to heal, and the clot never had time to become loosely adherent and actually be dislodged by the manipulation. A fresh blood clot is very adherent, not likely to be dislodged. And she did not reference some of the case reports out there on this topic as well. Another objection to the ideas I'm putting out here is some of these epidemiological studies are referenced to show no causal relationship between manipulation and stroke. However, the conclusions of these studies are not applicable to immediate post-manipulative stroke. These epidemiological studies, a limitation of these studies based on insurance claims data is establishing temporality. Claims data can establish whether stroke and manipulation occurred on the same day, but cannot establish the time lapse from manipulation to stroke, and cannot establish whether the stroke occurred before or after the manipulation. Therefore, these studies cannot establish temporality to construct an immediate cohort. All we have is a 0 to 1 day cohort in most of these studies, and the researchers must speculate on what came first, the manipulation or the stroke. The data does not tell them what came first. It just says you had a stroke on this day and a dissection on this day. Therefore, the conclusions of these studies as regards the 0 to 1 day cohort have substantial limitations, and it should be noted that Cassidy and Kozloff specifically state they had not ruled out a causal association between manipulation and stroke, and Wheaton noted that the mechanism of causation in thrombolic was plausible. So these studies do not support what a lot of people doing manipulation think they support. Tushin again discusses our last topic here. What about an artery that was susceptible to dissection, an unhealthy artery, an artery with Ehlers-Danlos syndrome type 4, an artery with fibromuscular dysplasia? These are not healthy arteries. The connective tissue in these arteries could tear more easily. Tushin states, it is plausible that manipulation could cause dissection in a susceptible artery, but it would not be likely to cause immediate thromboembolic or thrombotic stroke. It takes time for a thrombus to form, dislodge, embolize, and block a smaller artery that supplies the brain, resulting in thromboembolic stroke. It also takes time for a thrombus to form and become so large that it blocks the artery completely, resulting in thrombotic stroke. It takes 4 to 10 minutes for a blood clot to form. These do not form and dislodge immediately. So it is not plausible that that even in the case of a susceptible artery, it could tear immediately. There wouldn't be an immediate stroke. There would be an immediate tear, and the stroke would probably occur later, maybe much later, which was discussed by Dr. Hufnagel out of Germany. He stated that immediately after manipulation, if manipulation did cause a dissection, there would be immediate neck pain and headache, or maybe a brief episode of passing out or syncope. This may cause further immediate symptoms such as nausea, vertigo, or tinnitus, but a stroke is not likely to occur immediately, and it may not occur at all. If it did occur, it would not be until hours or days later due to enlargement of the dissection, causing a thrombotic stroke, or propagation of a thrombus, causing a thromboembolic stroke. So the moral of the story here is even if the manipulation does tear the artery, which is possible in a compromised artery, it is not likely to cause an immediate stroke. That's my study right there. We had to go through it really, really fast. If you have any questions or concerns, you can contact me. Here's my websites. My chiropractic website, brownchiro.com, my expert website, thechiropracticexperts.com. And again, the thrust of this study is that dissection has to be present before manipulation, because before manipulation could cause that stroke. In the past, it has been used as kind of an excuse for people doing manipulation, chiefly chiropractors, that, well, the dissection was there already. It wasn't our fault. It wasn't our fault because the dissection was already there. We didn't cause that dissection. But they're failing to recognize that they did cause the stroke because they did manipulation in the presence of that dissection. They failed to diagnose and refer that dissection. So the liability here as a chiropractic expert witness, I've never found one case where I thought manipulation caused a dissection, even in an unhealthy artery. But I've reviewed numerous cases of immediate stroke after manipulation, and my experience is that this is what happens every time. The patient walks into the office with a dissection, a very, very diagnosable dissection with distinctive symptoms: unilateral neck pain and headache, dizziness, nausea, a headache lasting for many, many days or weeks, not your usual migraine or cervicogenic headache, and the doctor of chiropractic misses the diagnosis. And to be fair, it's not just chiropractors who miss this diagnosis. There are other people doing manipulation, physical therapists, naturopathic physicians, some medical physicians, a lot of orthopedic physicians in Europe, in Germany do manipulation, and they're on record with case reports as having missed the dissection as well. So just because the dissection was there first does not relieve the person doing the manipulation of any responsibility for an immediate stroke. It was their responsibility to do a thorough history and examination and to make a note of that dissection and not manipulate the person and refer them to the medical emergency department. There was a 2019 study by Dr. Chaibi out of Norway, which puts together a very, very good treatment protocol or diagnosis protocol for this. I'd recommend you all check that out if this is the topic you find interesting. Chaibi and Russell, 2019 study out of Norway is very, very good. If you have any questions on this topic, please contact me. That's about 19 minutes right there. Very nice to meet you guys. Take care and enjoy the webinar.
Differential diagnosis and therapeutic effect. Because I think that it is a very huge argument, I try to split my presentation into two parts, chapter 1 and the chapter 2. The chapter 1 will be about the recent advances, so advances related to the last 5 years on the use of neurophysiology in the differential diagnosis of movement disorder. The second part will be about the recent advances on pharmacological effect on neurophysiological feature of movement disorder. So I would like to start from Parkinson's disease. And as you will know, the typical symptom of Parkinson's disease is the resting tremor. So in a recent study, there was a deep knowledge about another component of resting tremor that is called a reemergent tremor. So as you can see in the first graph, that is a recording of the EMG, you can observe the resetting of tremor when you ask to a Parkinson's patient to outstretch both arms. And of course, you can also perform a power spectral analysis in which you can observe the typical waxing and waning tremor power that is typical of emergent tremor. And it is very important because it could be helpful in clinical practice to differentiate the re-emergent tremor from core postural tremor. So we can use this tremor stability index to differentiate PD tremor from essential tremor, because the author observed that Parkinson's patient present with a lower tremor stability index. Another important neurophysiological tool that could be helpful in clinical practice is the quantitative EEG. That is represented by three techniques that are the spectral analysis, connectivity analysis, and also the network analysis that could be used in movement disorder. And the authors try to observe the presence of typical feature and the typical connectivity in specific brain areas to try to observe the possible progression of Parkinson's disease in Parkinson's disease plus dementia. So they observed this lower dominant frequency or increased theta power in correlation with cognition, and also like a predictive tool for future cognitive deterioration. Of course, quantitative analysis could be considered a biomarker of non-motor disease severity in patients with PD, but it is not so useful if you would like to examine or assess the treatment effect in Parkinson's disease. Recently, last year, there was this consensus opinion about the use of TMS in neurological disease, and I decided to put all the information here about the use of TMS in clinical practice for movement disorder, in particular from Parkinson's disease. But as you can see in the table, the use of TMS in terms of clinical practice and diagnosis has a very limited utility. So TMS continue to be a very important instrument, especially for research. About a typical Parkinson's syndrome, as you know, it is not so simple, especially at the early stage of the disease, to differentiate Parkinson's disease from the other atypical Parkinson's syndrome. So we can use, of course, TMS, as I said before, because as you can see in this table, there are some particular findings that you can find for each specific disorder. But sometimes it is not so easy to perform all these techniques because they require a very high skill competence. In particular, for cortical basal syndrome, there was this recent review that tried to summarize the main neurophysiological finding of CBS. So, for example, the presence of no jump somatory evoked potential in link with myoclonus or prolonged latencies of the cortical component, if you would like to recording the somatory evoked potential in a praxic limb. Of course, you can also observe the duration of the EMG bars in a couple of agonist and antagonist muscle. And of course, here it is reported also the use of TMS, in particular the theta bar stimulation, which you can observe an alteration in the long-term potentiation, long-term depression like plasticity. And in clinical practice, I think that it's very easy to perform also the cortical silent period that could differentiate normal subject from a CBS patient, in which, as you can see in this graph, there is the completely absence of the cortical silent period. For multiple system atrophy, as you know, if we perform a very not comfortable examination, that is the external Holland sphincter electromyography, it is possible to observe some neurogenic alterations that are related also to the presence of spontaneous activity. And it could be used to differentiate MSA patient from PD patient. But recently, last year, some authors tried to create a sort of pattern classification of that is related to the presence and severity of these neurogenic abnormalities, and try to observe the correlation with the survival prediction of MSA patients. So they observed that the electrophysiological environment is associated with a progressive worsening of prognosis. Of course, in clinical practice, it's not so easy to perform this kind of examination. I think that it could be easier to perform EEG examination, and some authors try to create this grand total EEG score, in which you can observe different items that you can find in each EEG trace, and every item is associated with a score. So, for example, if we think about the Parkinson's disease, we can observe this slow wave activity, or in CBS patients, it's typical to observe this very low voltage pattern, for example. And it is common to see other abnormalities also in PSP patients. So this focus low wave activity. So at the end, they elaborated this score, and observed that there was no statistically significant differences between Parkinson's disease and typical Parkinsonian syndrome, but there was a cutoff score of 9 that could differentiate idiopathic Parkinson's disease from atypical Parkinsonian syndrome with high sensitivity but poor specificity. Anyway, this kind of score lacked diagnostic power and differentiated particular subvariants of atypical Parkinsonian syndromes. This is one of our main research topic, because we try to use neurophysiology to differentiate atypical Parkinsonian syndrome. And in particular, we use the blink reflex to recovery cycle that usually assess the brainstem excitability. So we start from this differentiation between tauopathies, so PSP and CBS. And we observe that PSP presented this higher excitability of brainstem circuits, whereas CBS and controls presented a normal excitability. So we calculate the specificity and sensitivity of a two-blink reference recovery cycle to detect PSP versus CBS, and we obtain this important result because with high specificity and sensitivity, it was possible to differentiate the two tauopathies. Then we decide to continue our research goal, adding the group of MSA patients. And because the interstimulant interval of 100 milliseconds was the higher sensitive to differentiate a typical Parkinsonian syndrome, we decide to create a cutoff score at interstimulant interval of 100 milliseconds to differentiate CBS from PSP and CBS from MSA. And it was very surprising observing that despite the underlying pathology, because as you know, MSA is an alpha-synucleinopathy, so it is not a tauopathy, the behavior in terms of excitability of the brainstem was so similar between PSP and MSA, and we started to think that maybe in CBS patients we could observe a sparing of brainstem involvement. Then we decide to try to catch some differences at the very early stage of disease. So we enrolled PD patients that were drug naive, and we decide to calculate a two-blink reference recovery cycle from more affected side and from less affected side in PD, in MSA, and PSP. And then we created an asymmetry index of a two-blink reference recovery cycle to try to differentiate the disorder. And at interstimulant interval of 100, 150, and 200 milliseconds, as you can observe in the table, there were statistically significant differences in terms of asymmetry. So we created a further cutoff score to differentiate PD from PSP and PD from MSA, always with high sensitivity and specificity. Despite of it, as you know, the typical presentation of Parkinson's disease is clinically asymmetric, but also CBS patients usually present with this asymmetric onset. So we decide to use the symmetry index of a two-blink rapid recovery cycle, and to try to associate it with another asymmetry index that was a neuroradiological asymmetry index, considering the global mean cortical thickness, because as you know, in CBS patients, you can observe this asymmetric neurologically pattern in terms of atrophy of one of the hemisphere compared to the other one. And we obtain this asymmetric neurophysiological and brain structural pattern because in PD we have a very significant asymmetry in terms of R2-blink rapid recovery cycle, but no for the symmetry index of the cortical thickness that was present in CBS with the normal R2-blink rapid recovery cycle. So we can observe that, of course, it is probably that PD usually presented with a major involvement of brain stain, and in CBS we can observe a major involvement of neocortex, and the combination of the two asymmetry index could be useful in clinical practice to differentiate these two disorders, especially at the beginning of the disease. About the perkinetic movement disorder, I would like to show you this graph because if you see for the first time a perkinetic movement disorder, you have a presumptive diagnosis. But then in the middle, there is the use of the neurophysiology that could be completely change the final diagnosis of a perkinetic movement disorder. So sometimes we think that it's simple to differentiate myoclonus for tremor, but the clinical impression is not so real sometimes. So we have to associate other tests, especially neurophysiology, because neurophysiology could ask clinicians to observe, for example, the rhythm is typically irregular in myoclonus compared to tremor. Or if you think about this polymyography, we can observe a typical cortical myoclonus in which the pattern is a typical synchronous, and of course also the duration of the bars is very narrow. And if you would like to associate also this spectral analysis, you can observe that for frequency the base is very wide because cortical neuroclonus is typically regular, and there is a very high coherence, which is another typical neurophysiological feature for cortical neuroclonus. Of course, then you can use also the back averaging that could find a cortical correlate. When you decide to record a tremor, you have to follow a specific rule for the recording. So in this way, you can differentiate the 5 main tremor syndrome that are reported. For example, if you think about an physiological tremor, you can use the arm melody because the arm melody typically decreases the frequency during the recording. If we think about functional tremor, of course, distractibility could be very helpful in this kind of differential diagnosis. In this cartoon, it is reported a very useful clinical approach to jerk-like movements. So you can start with surface EEG, and of course, it is very important to choose the right muscle that have to be recorded. And then you can pay attention to the burst duration, because if you have a burst duration that is less than 50 milliseconds, now you have to think about cortical myoclonus or peripheral myoclonus. But if this burst duration is wider, then you have to start to think about the different anatomic generator for myoclonus. For example, protospinal myoclonus. In this case, because in the 90% of case, the nature of protospinal myoclonus is functional, it is important to associate another test like Bereshaft potential, because the Bereshaft potential helps clinicians to differentiate the functional from organic protospinal myoclonus. Now I would like to go on about the use of neurophysiology to evaluate also the treatment and the efficacy in treatment for Parkinson's disease. I would like to start with a study because it is a study that uses the coherence. We know that the coherence between antagonist muscle is high. There is a high degree of common drive rigidity as well as bradykinesia is worsened, whereas decreased coherence will represent a more dynamic and physiological movement pattern. So the authors decide to evaluate the coherence 1 day prior to DBS implantation surgery and after 6 months of the surgery. And they use these clinical tasks that are here reported in detail. So they observe a significant correlation between the peak coherence and the change in UPDRS for all the 3 tasks. So this correlation was very important to demonstrate that the patient with a higher intermuscular coherence during home measurement typically had a better clinical outcome after DBS. So the author suggests to use the coherence in the selection process for SPM DBS. I think that there is something new that we can think about it, about also the use of neurophysiology in healthy clinician, also for the therapeutic approach of Parkinson patient. Recently, we published this work in a movement disorder journal about the long duration response to levodopa, motor learning, and neuroplasticity in early Parkinson's disease. A lot of study about the long duration response to levodopa, they are from 90s because there was, I can say, a decrease in interest about this pharmacological outcome. Typically, levodopa is the gold standard in PD treatment option, and the therapeutic response to levodopa consists of 2 responses that are the short duration response and the long duration response. The short duration response is a clinical improvement lasting 3-5 hours after a single dose of levodopa. So it is related to the plasma concentration of the drug, whereas the long duration response is the sustained anti-Parkinsonal benefit derived from prolonged administration of levodopa. So it is not related to the pharmacokinetic of the drug. In 2010, there was this paper that was published in Annals of Neurology about the first animal model of long duration response. They were the THX3 mice. These mice were depleted of tyrosine hydroxylase. So the study at the aim to try to observe the motor learning in these mice that have to learn a motor task on a road. So authors started to administer a single dose of levodopa that are here represented in gray shade. As you can see, day by day, these mice start to build, and it is a report in the blue shade, the long duration response of levodopa that correspond also to the performance, because these mice with this single administration of levodopa started to learn the motor task. Then there was the withdrawal of levodopa that is represented by the break point, and these mice didn't lose the motor task immediately, but day by day they started to come back to the baseline condition. So after reading this article, we were thinking, okay, long duration response could be a manifestation of the rescue motor learning in this kind of models, animal model. So it could be something similar to a subject with the long duration response, or human subject. Then we designed our study. We decided to enroll only drug-naive PD patients, and they were evaluated both clinically and neurophysiologically as baseline condition. We used 3 neurophysiological tests that were presented by P300, multiple potential, and very sharp potential, that are considered surrogate markers of neuroplasticity. Then patient underwent a levodopa challenge test and started treatment with levodopa at a dosage of 250 milligrams once a day at 8 o'clock with the interstimular interval of 24 hours. Patients were also randomized for the performance or not of a motor exercise with aim to produce a motor learning. So after 15 days of treatment, they were evaluated clinically, neurophysiologically. Of course, there was the assessment, the evaluation of the achievement of the long duration response, the patients were evaluated without the drug and up to 2 hours they take of levodopa, so baseline and peak condition. So at the end, we obtained 4 groups of patients according to the achievement of the long duration response or to the performance or not of motor exercise. We enrolled also a normal subject, observing that there was an alteration of all the neurophysiological parameters in PD patients. Then we observe at the end of this 50-day of treatment the differences in neurophysiological parameters between the 4 groups. And of course, you can also observe differences in terms of T0 at the baseline. In gray, there is the T15 at the baseline, so without the intake of levodopa, and the T15 peak is after 2 hours of the intake of the drug, so in non-condition. And we observe a significant improvement in latency of P300 only in the first group, the group that achieved the long duration response and at the same time perform the motor exercise. And there were differences only between baseline and the T15, despite of the intake of levodopa that is related to the short duration response, not to the long duration response. We can observe a similar result also for motor evoked potential. A is represent the motor evoked potential amplitude, B the cortical silent period, C the resting motor threshold in terms of latency, and D the active motor threshold in terms of latency too. And we observe also in this case a significant improvement in this parameter only in the first group. For the Bereshev potential, in the upper part of the graph, you can observe the early component of the Bereshev potential, in which A is latency, B is amplitude, and in the lower part there is the later component of the Bereshev potential, in which C is the latency and D is the amplitude. So there was an improvement only in terms of latency, both for the early and later component, and this improvement was present in the first but also in the second group. So the groups that achieved the long duration response despite of the performance of motor exercise. So if we would like to summarize all this data, we can say that the neurophysiological parameters were altered in PD, and most of these detective abnormalities could be restored by the treatment, but at the same time could be modified by the exercise. In our case, motor exercise did not produce modification neurophysiological marker in absence of the achievement of the long duration response to levodopa. And the effect of the short duration response were irrelevant for most of the neurophysiological parameters investigated. So this dopaminergic effect on neurophysiological parameter was entirely due to the long duration response. And of course, the group that achieved the long duration response at the same time performed the motor training presented with an optimal recovery. So we think that there is a possible synergistic effect between pharmacologic response and motor activity. And the long duration response could induce an adaptive change and expression of neuroplasticity in basal ganglia and cortical network. We observe something similar in our previous study, in which we tried to observe a predisposition in patients that can develop the long duration response compared to that patient that don't usually develop the long duration response. And we observe this presence of changes of gray matter volume in brain cortical areas that are involved in motor control. And these are the same areas that were investigated by the surrogate marker of neuroplasticity, that are the neurophysiological parameter that we considered for the study. So it could represent a structural predisposition leading to the achievement of the long duration response to levodopa. So our findings for the long duration response could be a pharmacological outcome for clinicians to facilitate motor learning and its action on neuroplasticity in early Parkinson's disease. So we have to start to think about a new way to manage Parkinson's patients. And my last slide is a sort of advice, because I think the neurophysiologist very crucial when we would like to manage especially hypokinatic movement disorder. So I propose this algorithm that use neurophysiological tests that are no time consuming, no expensive, and no require high level skills. So when you have a hypokinatic movement disorder, you can start with a grand total EG and the use of asymmetry index of a two-blink referral recovery cycle to differentiate early Parkinson's disease from atypical Parkinson's syndrome. In the second phase, then you can further use the cutoff score that you previously with me learned during the presentation, and of course try to associate the asymmetry index, is the neurophysiological one, with the asymmetry index, is the neurological one, also to characterize CBS from ED. If you are sure that your diagnosis is that of drug-mediated Parkinson's disease, then you can start a treatment that could have this outcome to achieve the long duration response to levodopa, and try to evaluate the responsiveness to the dopaminergic treatment, but also the presence of this kind of plasticity through the use of this kind of neurophysiological parameters. So thank you.
Thank you. I would now like to open the floor for
important in analyzing and managing our patients. I'm going to talk specifically about the cognitive and emotional outcomes, which we call neuropsychological outcomes in COVID-19. I think after the first pandemic of 1917, the second one, the second largest one of 2019, 2020, 2021, has left the world devastated in many ways, both health-wise and in terms of financial sectors. And the progression of COVID-19 has prompted many countries to look at ways of managing current and future pandemics. It has left no ages unscathed. We've even had infants who seem to have made better recoveries from COVID-19, but it's also affected them in many ways, prompting the development now of FDA-approved vaccines from 6 months of age. So the treatment for COVID initially started as being symptomatic, broad-based, and symptom-based. And very many of these patients were treated on a home-based basis because of the lack of beds with the increasing numbers. The vaccine themselves took stages in their development. And as you probably know, there was widespread skepticism, particularly in those developing countries, about the efficacy of these vaccines. And home remedies then became not only the mandate of rural communities, but there were some medical professionals who punted that idea. However, we now know that the mRNA vaccines seem to be the most promising types of management for these kinds of infections. We have come to learn that the mechanisms of COVID-19, because of the way and the types of infection statuses, has many kinds of symptoms. We know that it now has some involvement of the nervous system, and we think that the ACE2 receptors, which are abundant in the parenchyma, may be the site of invasion for these viruses. We also know that the acute effects can be quite diffuse and widespread and include non-specific types of symptoms like headaches, anosmia, which has now become a cardinal symptom. It can result in some kind of symptoms of stroke. We also get seizures, and I'll talk about the types of seizures they could initiate. And in more severe cases, we get encephalopathy. Fortunately, in many cases, the recovery can be quite complete. And in many other cases, there are persisting symptoms that can be very singular in terms of the system involvement, or there could be multiple in their system involvement. What is peculiar about these pandemics is that very often there's a sociogenic basis to it, that in communities where there are one or two cases, and then it becomes widespread because of the infectious nature, there is this kind of cultural dissemination of information, sometimes not based on good science, but based on home interpretations and cultural interpretations of these illnesses. So the symptoms that we see are sometimes mental and physical fatigue, but very often we see cognitive changes where patients begin to complain of memory difficulties, concentration difficulties, and associated types. There are often sleep disorders, either somnolence or the other end of it, it could be insomnia. We also have these affective changes, and it's quite obvious that there's a lot of anxiety about contracting the condition and having some kind of severe reaction to it. There's also depression, and very often there's post-traumatic stress disorder. And because of the major way of managing it is social isolation, we have the social effects, which are long-term, and we're now beginning to see it amongst families, amongst children, amongst couples, and in kinds of certain types of employment sectors. Because of these situations, and because of these enduring symptoms, the National Institute for Health and Care Excellence have given two types of definitions for these ongoing symptoms. They identified firstly the ongoing symptomatic COVID-19, and those are signs and symptoms of COVID-19 that range from about 4 weeks to 12 weeks. So those are not very long and enduring. But those that occur from 12 weeks and above, they call it the post-COVID-19 syndrome. And there's a large pool of survivors worldwide, up to almost 500 million at the latest estimates from World Health Organization, who could typically be classified as post-COVID-19 syndrome. It usually presents with clusters of symptoms, and then the symptoms then begin to overlap. And then as they change over a period of time, they begin to present a very difficult kind of complex of symptoms to diagnose. So what we have is there are multiple factors because of the sociogenic nature of the illness that is not isolated to one person, but to two people, to families, and then to large communities. There are several factors that begin to predict what the outcome of this COVID-19 is in neuropsychiatric outcome. We do know that PET studies show us there's hypometabolism, that there's certain areas of the brain, the frontal lobe and the amygdala areas, and particularly the subcortical, begin to show certain kinds of low activity in uptake of glucose. We also know that inflammation is one of the causal factors, and that's because of the overactivity of the systems of immune systems that begin to operate. And then there's ischemic values, and the ischemia begins to show itself into certain kinds of blood circulation problems, and as I mentioned, pseudo type of stroke syndromes. And this is because we think there is this direct viral invasion of the neural vasculature and the neural systems. But from the patients we've seen at a large sector of individuals is that the social impact becomes a very crucial and critical component of how the disease evolves and how the symptoms becomes apparent in an individual. Because of this, people who have been largely affected, unfortunately, have been those who have contributed to the employment sector and those who have become the financial generators for their families, for their communities, and for the societies. And we've seen this widespread financial impact worldwide that we think that's going to lead to another worldwide economic depression. But apart from that, we see that social isolation has left people with individualized kinds of psychosocial problems. This partner and spousal disability and death that has had a very powerful impact on families. Family deaths have also had serious impact on the individuals as well as family cohesion. The loss of employment is another social factor that has impacted individuals as companies suffer the effects of the loss of employment and production. And very often we have those who survive. There is now, what is the capacity for return to work? Do these individuals qualify for disability because of their enduring symptoms and the poor work ethic? So there is the societal effect worldwide that is going to leave us for years to come as we return and attempt to return to some economic viability. I'm just going to talk about a case study of a very high functioning patient, a female patient, who was second in charge in a banking sector. She was second to the CEO. She had multiple postgraduate and graduate degrees. She was married to a physician. She had 4 children. And there was no evidence of psychiatric history at the time that we took this patient in and we did a history of her background. And she's a typical patient that we find in very high functioning societies where individuals have been affected with the COVID virus. When we took her in, this was a medical history. On day 1, the COVID-19 diagnosis in this patient. She also had on day 2, her father and sister who lived away from her were also diagnosed with this condition. So there was this already mutual separation of father, sister, and this patient, although she lived in the context of her husband, who was a physician, and 4 children. The initial symptoms were the typical COVID symptom presentation, high fever, but she also had some delirium. And the delirium, according to the physician, the husband whom I'd spoken to, was quite severe. She had some anosmia, she had some loss of taste as well, and obviously she was disoriented and she was quite weak. The home test on her home SATs was 88%, and immediately she was removed from the home to try and get her into a hospital. And unfortunately, because it was at the peak of the pandemic, she was not admitted because there were no home beds. There were no beds in hospital, and she was treated, she was treated at home by her physician, who was her husband, with some antibiotics, with fluids, with oxygen support. He was also able to give her some mechanical ventilation and intubation to support her. She was very fortunate in that respect, that she had somebody close to her who could offer her very near to what a hospital could offer her. After 12 months, she showed a fair amount of recovery and she returned to work, and she was forced to return because the company was putting some kind of pressure on her to return. But her complaints of mental fatigue, confusion, and she began to show difficulties remembering simple work routines. Although she was in a high executive position, she had to take some executive decisions. And she began to show those difficulties in executing and remembering which particular routine to select. What was very interesting was also she began to present with seizures. And the neurologist who examined her began to find that her seizures were not true seizures, but they were more psychogenic, non-epileptic seizures. And I'll show you the test results later on. Around that time, very sadly, she learned of the demise of her sister. And her father had survived, but her sister, was much younger, had demise. And that presented tremendous strain on her psychological findings. The other psychosocial problem she had was a spouse who had treated her and lived with her during the 12 months began to initiate divorce proceedings because he felt that he could not deal with the social isolation, the feelings of rejection, her problems that she emanated during the delirium. And sadly, he took his own way of exiting the relationship. Depression obviously set in, and she was referred to a psychiatrist who treated her very vigorously and aggressively, even giving her some TMS. She had a lot of anxiety. She went in for occupational therapy. And because of the continued presentation of a PNES, the psychogenic seizures, she was presented for this brain scan, and the MRI interestingly showed the presence of frontal non-specific deep white matter hyperintensities, indicating that there was some kind of vascular involvement. But more interestingly, 24-hour video EEG was entirely normal. There were no abnormal kinds of findings. So she was referred to us for some neuropsychological assessment to say, we need to know what about the cognitive status of this patient, the emotional findings of this individual. Can she return to that high level functioning of her work where she needs to make executive decisions that obviously involve large, very large capital sums of money, and a lot of other individuals dependent on her decision making. When we saw her, she was fully oriented, but she obviously showed some amnesia for the acute phase, and particularly for the time when she was in a delirium. She recalled none of those episodes. She was able to manage a computer system quite adequately, though. She was able to understand and navigate the test, and we saw her remotely because she was located in a different province to where we were situated, but she took an extended time to complete the test. We were fortunate to see her on 2 occasions, and I'm not sure if you can see this slide. It's a small print, and I apologize for that. We were able to see her twice, 1 week apart, just to establish the validity of her findings. And we were fortunate in some cases also to have parallel tests so that we don't have any kind of repeat effects. And here's very interesting, that some of the test results improved after a week. For example, we found that in the case of her verbal memory, while she was low average in the first instance, when we repeated it 1 week later, she was average. And then there were other tests as well that showed a little kind of increase. For example, the test result where the Ray complex figure, where she was asked to draw stuff and remember it, she showed some impairment in the first time, and in a week later, she showed mild improvement. There are other tests where she showed severe deterioration. For example, in her memory. First time she showed mild impairment. The second time she was impaired with confusion. And here we deliberately repeated the test using the same stimuli. This drew us to the attention that her pattern of performances were on the cognitive tests were inconsistent and not according to what we expected with a gradual return of recovery of a COVID patient. So we went ahead and we did some emotional findings. And we looked at the Epworth Sleepiness Scale, and we saw that she had a sleep disorder to some extent, and we referred her to a sleep specialist. We also saw quite expectedly that she had very high anxiety, depression, and stress levels, all of them falling in the severe range. But very interestingly, and this test is hardly used, we looked at the somatization test, and she showed she had very high somatic symptom burden. That means she began to exaggerate and become oversensitized to the various symptoms she had. And quite obviously, as we said, that she had high levels of scores on the depression and on the post-traumatic scale. Now, the post-traumatic stress scale was very interesting. The items she identified were the intrusion of the COVID trauma, not of those that affected her directly, but those that affected her father and sister. And to some extent, her sister's death and the loss of a sibling during an experience that she went through was the most traumatic incident for her. She likened her COVID infection to what she called was a near-death experience. She felt, and she identified with her sister's death, and she began to understand and realize that she had come close to death herself. She attributed this whole experience to the continued dysfunction in her family and the loss of her husband. What we decided to do then is to summarize our findings and say that we cannot isolate her cognitive functions and say they are independent and they're due to some kind of cerebral dysfunction, even though she had the white matter intensities, even though she had fatigue, even though she had sleep disorders and affective changes. We identified that the post-traumatic stress disorder and the social isolation during her time of treatment constituted two of the most significant factors that contributed to her disability. We also began to suspect, based on the fact that she was having psychogenic seizures, that she was somaticizing a lot of her somatic complaints. That means she began to exaggerate them, and she began to overestimate them, and she began to attribute some of her simple symptoms and the simple complaints to the excessive personal assessment of the somatic symptoms. Now, there's a very interesting article that emerged by Joffe and Elliott in 2023, and this is in Sage Open Medicine, Volume 11. These authors now point to the central sociogenic basis of pandemics, the very nature of pandemics, meaning that it's not isolated to one individual or two individuals, but it has a rapid exchange and transfer across individuals and across communities, means that we cannot ignore the central sociogenic basis and all the aspects of transmitting information about illnesses in a community. And they also suggest the majority of long COVID should be considered a functional disorder, which is due to either predisposing kinds of mental conditions, or it could be due to precipitating factors such as the depression, the anxiety, and the post-traumatic stress, and the perpetuating factors, which are, in this particular case, the post-traumatic stress disorder. There is no doubt that COVID has left individuals with experiences that were far-reaching and beyond the acute and the post-acute phase. The memory of the traumatic deaths of individuals. And in this case, this patient remembers seeing her sister slowly deteriorating into loss of consciousness prior to herself falling into the delirium state. So what we recommended? We said that in pandemics, there's a strong influence of life events. No illness and no disease occurs in a vacuum. And we've learned this so much from the COVID pandemic, that we are all social beings, and being in social connection with one another not only staves off illnesses, but also enhances the whole process of recovery. We also felt that the near-death experience this patient experienced, going through that whole delirium experience, the anxiety, the depression, the post-trauma, and the loss of natural respiration requiring intubation, meant for her that she was in almost a deathbed. And the ensuing social sequelae, and that is in particular the loss of her marriage, became a very traumatic experience for her. Some of the cognitive deficits were, however, reliably established. We managed to show that she did have concentration problems. She had a problem remembering information in the near term and recalling some of the old information. And we thought that perhaps there was this problem of retrieving old types of information she had learned over time. However, we could not deny that she was somaticizing. That means there was this emotional cry for help. There was this emotional need that she had. I've lost my marriage, I've lost my sister, I'm on the threshold of losing my financial independence. And all of these symptoms then became a huge burden and became a part of the somaticization and the physical expression of her emotional needs. Her profile suggested, therefore, for us some kind of mixed findings. She did have cognitive, thinking problems, retrieval problems, memory problems. She did have an amnesia, obviously, for the acute phase of the injury. She had huge affective responses, the major part of which was post-traumatic stress syndrome that is sometimes ignored in the management of these patients. And there was somaticization, and we used certain kinds of cognitive rehabilitation and cognitive desensitization to reduce the somaticization. We then came to the conclusion that our overall diagnosis could be considered more a functional disorder, and what we began to call the functional disorder of long and enduring COVID-19. So we feel that in future pandemics, it's important to improve the accuracy of medical reports so that society in large begin to get more accuracy in terms of what is the medical basis for any kind of pandemic. Is the virus as contagious? Is the virus as severe? What are the risk factors you as an individual should be aware of in reducing the severity of an infection should you acquire one? We should also aim to reduce long periods of isolation. Those, if you recall, were mandated by governments worldwide, that isolation from not only from between individuals, but by families. This was reinforced by the medical individuals as well. But we begin to understand that social isolation reduces, of course, the immune system, which we're all quite familiar with, but it has a secondary effect that reconnecting with individuals after the isolation period becomes a real challenge and can lead to dysfunctioning in relationships between individuals and within families. So improving social supports in the acute and post-acute phases becomes an important part of the management of pandemics. And we are certainly not free from this happening again. And for us, the important thing is that the serial neuropsychological assessment, brief assessments that will give us some idea of what is the degree of somatization in the symptom presentation of these individuals. At that point, I'd like to stop and take any questions you might ask, and thank you for listening to me.
May I ask a silly question?
Sure.
Good afternoon, everyone. I am Dr. Satyanarayana Kumari, Assistant Professor of Radiology, working in All India Institute of Medical Sciences, Nagpur, India. Today, my topic is determination of efficiency of 3D fluid attenuated inversion recovery sequence, that is FLAIR, in the imaging of multiple sclerosis in comparison with 2D phase sequence at 3 Tesla MRI. Introduction of the topic. Magnetic resonance imaging plays a key role in the diagnostic workup of multiple sclerosis. Hence, the MRI was the main component in both original 2001 McDonald's criteria and their 2005, 2010, and 2017 revised versions. Fluid attenuated inversion recovery, FLAIR, measures a high intensity of T2 weighting with the attenuation of cerebrospinal fluid signal. The FLAIR was primarily performed as a 2D acquisition. Subsequently, a newer 3D sequences have been implemented. These 3D sequences allow thin contiguous slices with multiplanar reconstruction, high spatial and contrast resolution, good signal-to-noise ratios and contrast-to-noise ratios, and thereby improved detection of smaller lesions. Initially, 3D FLAIR sequences were primarily conducted using a multi-slab approach, which led to emergence of Venetian blind artifact when the resulting images were remodeled. The single slab type of 3D FLAIR sequence was taken into consideration to eliminate this artifact. The field strength is directly proportional to high signal-to-noise ratio. The enhanced signal-to-noise ratio observed at higher field strength in imaging can be harnessed either to shorten the imaging duration or enhance spatial resolution. Markedly reduced motion artifacts were seen with a single slab 3D FLAIR sequence as compared to a 2D FLAIR sequence in the brain imaging at 1.4 Tesla. Furthermore, almost no CSF flow artifacts were seen with the 3D FLAIR sequence in brain imaging. In addition, 3D data sets are compatible with computer-aided analysis. To our knowledge, there are only few studies comparing 3D FLAIR and 2D FLAIR sequences regarding multiple sclerosis lesions at 3 Tesla MRI. Most of the previous studies were done on the 1.5 Tesla MRI. The present study aims to test the single slab 3D phase sequence for multiple sclerosis at 3 Tesla. For this purpose, we collated a single slab 3D phase sequence to a standard 2D phase sequence, considering the number of multiple sclerosis lesions detected, signal to noise ratios, and contrast to noise ratios in the brain. Material and methods. This is an observational prospective comparative study, and the informed consent was obtained from all the included participants. The Institutional Human Ethics Committee of KIMS Health issued approval for this research. A total of 75 patients, 80 males and 57 females between the ages of 15 and 65 years with a clinically definite multiple sclerosis undergoing MRI brain at the Department of Radiology, Krishna Institute of Medical Sciences, Secunderabad, India, were included in this study. Inclusion and exclusion criteria. All the patients with clinically diagnosed multiple sclerosis undergoing MRI brain imaging at the Department of Radiology, KIMS Hospital, were included in this study. The patients with concomitant neurological disease in addition to the multiple sclerosis, patients with history of claustrophobia, patients with a history of cardiac pacemakers, prosthetic heart valves, cochlear implants, and any other implants in the body, and the patients who did not consent to be a part of the study were excluded from the study. MR image acquisition. A 16-channel phased array coil was used at a 3 Tesla MRI system. We have obtained an additional sequence, that is 3D phase sequence, along with the routine MRI sequences including 2D phase sequences for a multiple sclerosis. 3D phase sequence refers to a single slab 3D fast pinicode T2 phase sequence. The 2D phase sequence was acquired in an axial plane, while the 3D phase sequence was obtained in a sagittal plane, which was then reformatted into axial slices. And the slice thickness of 2D phase sequence was 5 mm and the 3D phase sequence was 0.9 mm. Image analysis. Only axial slices were used for evaluation. 2 neuroradiologists, each possessing a minimum of 5 years experience in the field, assessed the lesions and reviewed the sequences in a randomized manner. The lesions were calculated and assigned to the following brain regions: periventricular region, non-periventricular and juxtaventricular region, infratentorial region. The analysis of contrast to noise ratio was done through a random selection of 3 lesions from 3 regions, 1 from each region in each patient, and in each patient the same 3 lesions were assessed for signal intensities in both types of sequences used. The CNR was measured as a signal intensity in the lesion minus signal intensity in the tissues divided by standard deviation of noise, and SNR was calculated as signal intensity in the tissue divided by standard deviation of noise. To prevent any artifacts, the standard deviation of noise was assessed in the designated area of the study outside the brain. Statistical analysis. In this study, we used SPSS software version 17 to perform all the statistical calculations. The total number of lesions identified on the 2 sequences was compared by using an independent sample t-test. The CNR and SNR measured on the 2 sequences calculated using a Mann-Whitney U-test. Results. More number of lesions detected in non-periventricular and juxtacortical region than periventricular or infratentorial region. Distribution of lesions in the cerebral parenchyma on the 2D flare and 3D flare sequences shown in the figure 1. This is the figure 1, distribution of lesions in the cerebral parenchyma. On the left side figure, image A is a 2D flare, and on the right side image B is a 3D flare. In both the sequences, more number of lesions detected on non-periventricular and juxtacortical region. And the 3D flare sequence detected significantly more number of lesions as compared to 2D flare sequence. The total number of lesions detected on 2D flare sequence was 3,317, and on 3D flare sequence was 5,378 lesions. A total of 2,061 more lesions were detected on 3D flare sequence. Table number 1, the number of lesions detected on 2D flare and 3D flare sequences are shown. Significantly more number of lesions detected on 3D flare sequence than 2D flare sequence. And the difference between the two sequences is statistically significant with a p-value of 0.001. And the 3D flare images exhibited significantly high signal-to-noise ratios for lesions, CSF, white matter and gray matter with a p-value of 0.001 and markedly increased contrast-to-noise ratios intermediating the lesions and CSF, white matter and gray matter with a p-value of 0.001 than 2D flare images. This is the table 2. Shows signal-to-noise ratios and contrast-to-noise ratios of 2D flare and 3D flare. Significantly higher signal-to-noise ratios and contrast-to-noise ratios are seen in the 3D flare sequence than 2D flare sequence. The difference between these two sequences is statistically significant with a p-value of 0.001. Discussion. When the 3D flare and 2D flare sequences were compared, the single slab 3D flare sequence was dominant over 2D flare sequence regarding the evaluation of number of lesions, high signal-to-noise ratios, and contrast-to-noise ratios. The spatial and contrast resolution are higher with a single slab 3D flare sequence than conventional 2D flare sequence. The 3D flare sequence detected more number of lesions than 2D flare sequence. This was due to the identification of small lesions that remained undetected on 2D flare images. Moreover, in the 3D flare sequence, it was possible to distinctly appreciate the discrete lesions apparently confluent on 2D flare sequence. This is a figure 2. A1 is a 2D flare image and A2 is a detailed enlargement of the A1. B1 is a 3D flare image approximately corresponding to the A1 and B2 is a detailed enlargement of the B1. This image shows there are lesions detected on the right centrum semioval on 3D flare which are not visible on the same region in 2D flare. Significantly more number of lesions detected on the 3D flare image and the white matter lesions are clearly detected visible on 3D flare images. This is a figure 3. C1 is a 2D flare image and C2 is a detailed enlargement of the 2D flare image. D1 is a 3D flare image and D2 is a detailed enlargement of the 3D flare image. In this image, the lesion seen in the subcortical white matter of the right parietal lobe is actually consists of two separate lesions. But on 2D flare image, it appears as a single lesion. But if we see on 3D flare image, it actually consists of two separate lesions. This is due to a slice thickness of 0.9 mm in 3D flare sequence. And this is a figure 4. E1 is a 2D flare image and E2 is a detailed enlargement of the 2D flare image. F1 is a 3D flare image approximately corresponding to the E1. F2 is a detailed enlargement of the F1. In the 3D flare image, lesion is seen in the splenium of corpus callosum, but the same lesion is not seen in the 2D flare image of the same patient. This is a figure 5. G1 is a 2D flare image and G2 is a detailed enlargement of the G1. H1 is a 3D flare image. H2 is a detailed enlargement of the H1. On 3D flare image, There are lesions detected on middle cerebellar peduncle, right? Middle cerebellar peduncle and cerebral hemisphere and bilateral temporal lobes, which are not seen on 2D FLAIR images. And this is the figure 6. I1 is a 2D FLAIR image. I2 is a detailed enlargement of the I1. J1 is a 3D FLAIR image. J2 is a detailed enlargement of the J1. On 3D FLAIR images, lesions seen on 3D FLAIR image in the bilateral cerebellar peduncles, which are not seen on the 2D FLAIR images. Our results specifically highlighted the impact of slice thickness, comparing 0.9 mm slices with no interslice gap of 3D FLAIR sequence to 5 mm slices with a 2 mm gap of 2 mm interslice gap of 3D FLAIR sequence. The sequence revealed a total of 2061 additional lesions compared to 2D FLAIR sequence. The results of the current research align with the conclusions reported in the research conducted by Tervedi et al., Melki et al., Molinix PD et al., in which multi-slab 3D FLAIR acquisition with decreasing slice thickness of 5 mm, 3 mm, and 1 mm demonstrated improved lesion detection of small lesions at 1.5 Tesla. In our study, we observed that the number of detected lesions in the infratentorial region was notably limited, a finding consistent with other observations of other researchers. For this reason, McGowan and Patel suggested that the FLAIR sequence was not recommended for the infratentorial region due to significantly distinct relaxation times compared to the supratentorial parenchyma. While 3D FLAIR may increase the identification of supratentorial white matter lesions, but alternative sequences may be required for the best imaging of infratentorial regions. 3D sequences offer advantages in terms of signal strength and contrast properties, even when utilizing small voxels. Our measurements confirms these results, demonstrating higher values for all calculated ratios. The assessment of signal to noise ratio and contrast to noise ratio values followed a methodology like the one outlined by Tan et al. The current research shows that signal to noise ratio values for lesions, CSF, white matter, and gray matter were notably higher in the 3D FLAIR images with a low p-value of 0.001. The results of the current research aligned with the conclusions reported in the research conducted by Parzig et al., Benke et al., in which 3D FLAIR images showed higher signal to noise ratio values for lesions, CSF, white matter, and gray matter. A 2D FLAIR sequence used a conventional spin echo trained with 180-degree refocusing RF pulses, while a 3D FLAIR sequence used an extended spin echo trained with a different flip angles. The above mentioned differences in echo train could reasonably result in quantitative disparities in signal intensities. The present investigation, 3 reference tissues that are CSF, white matter, and gray matter showed significantly higher CNR values in 3D FLAIR images with a p-value of 0.001 than in 2D FLAIR images. Therefore, 3D FLAIR imaging gives a better image quality and signal quality for these brain structures compared to 2D FLAIR imaging. The results of the current research aligned with the conclusions reported in the research conducted by Padzigam et al., Binke et al., in which 3D FLAIR images showed higher contrast to noise ratios values for the CSF, white matter, and gray matter. These improvements can be attributed to the single slab design inherent to the 3D FLAIR sequence. The 2D FLAIR sequence is acquired in 4 minutes. In addition, the 3D FLAIR scan can be performed in 5 minutes, which is clinically acceptable. We hold the view that employing a standard diagnostic protocol comprising 3D FLAIR a T2 weighted sequence specifically tailored for infratemporal regions, and a 3D T1 weighted sequence with a pre and post gadolinium contrast administration offers a high degree of sensitivity and effectiveness in multiple sclerosis imaging. Our study has few limitations. A limited number of patients were examined without the inclusion of control group. 2D phase sequence with a slice thickness of 5 mm and interslice gap of 2.2 mm differed substantially from a single slab 3D phase sequence with a slice thickness of 0.9 mm and no interslice gap. Optimal imaging of infratemporal regions require a variety of sequences because phase sequence may not be effective for this area. We did not assess the potential utility of 3-flare imaging in detecting lesions in the spinal cord, cortical regions, and in optic nerves. Cortical and optic nerve evaluations were included in the 2016 magnetic resonance imaging in multiple sclerosis. It is possible that improvements in MRI technique will influence the diagnostic criteria for multiple sclerosis. The latest additions to the McDonald criteria for multiple sclerosis diagnosis, incorporating the MRI criteria, have relied on imaging studies conducted at magnetic field strength of 1.5 Tesla. The combination of 3 Tesla MRI with 3D phase sequence, as shown in the current study, can be valuable in diagnosing multiple sclerosis. Conclusions. A single slab 3D phase sequence identifies a greater number of lesions as compared to 2D phase sequence. The upgraded presentation of 3D phase sequence can be recognized to the presence of substantial quantity of thin contiguous slices, high spatial and contrast resolution, remarkable increase in signal to noise ratios, and contrast to noise ratios provided by the technique. The effectiveness of 3D sequences in multiple sclerosis diagnosis is still under research, as is their potential. However, the confirmation of this will require larger scale studies. The current study indicates that 3D phase sequence is superior to conventional 2D phase sequence with respect to multiple sclerosis imaging. 3D phase sequence can take over 2D phase sequence in MS multiple sclerosis imaging in the future. The diagnosis of multiple sclerosis at the initial phase can be expected by using high field MRI, that is 3 Tesla MRI, combined with the 3D sequences. These are my references. Thank you.